Yeah, well, this is, this has been a major development in the last very few years. We're talking about innovative form of immunotherapy, these CAR T cells. A lot of hype, a lot of expectation, a lot of press, since we're talking about press here, maybe even too much because there's been enormous expectation. So these are engineered cells that are engineered to recognize the neoplastic cells in the patient through T cells of the patient. This is obviously a very revolutionary approach, which is giving some very interesting and encouraging results. I don't want to overemphasize, but I'm always very careful when there's so much publicity that I put myself in the shoes of patients and families. So we have to be very careful. But this is, I think it's a major breakthrough, in fact, in general, because we had some very interesting results. Where it's going to go is the key question, because it's very much, it's complicated procedure. These cells are engineered. You need adequate laboratories, and so far it's mainly commercial, a few academic centers doing it. So very cumbersome to go ahead, and the commercial products are extremely expensive. So there are a big practical problem. So I think it's a tip of an iceberg of a revolution of changes, and we'll see major developments using these procedures in patients with less advanced disease. Well, that goes a bit as a consequence of what I was saying. I think we have to look ahead. I mean, as all innovative treatment, when they get to the clinic, you treat patients with advanced disease. And that means, as I mentioned, some important results. But that's not going to be the end point. That is a starting point. All these innovative treatments have to move at an earlier disease phase, where you have less disease, not as a last resort in a patient out of 5, 6, 7 relapses. The future is going to be incorporating these approaches much earlier. If we're talking about acute leukemias, as I see it, this is to try to prevent the first relapse, to try to increase the cure rates up front. That's what we want to do in an acute leukemia. That, I think, is going to be the major development. Or else use them with minimal disease, where you will reduce the toxicity and have a higher rate of success. So that is the physiological, at least as I see it, development of CAR T cells in the management of patients with hematological malignancies, since we're talking about hematology. Okay, this is another fundamental chapter in management of hematology or tumors in hematology, because for many hematological malignancies, we can accurately monitor minimal residual disease. I mean, I grew up in the days when it was mostly morphology. And now we have much more sophisticated approaches by flow cytometry and mainly by molecular testing, where you can quantify precisely how much disease is still there. Why is this important? I mean, this was academic in the old days. Now it's part of the clinical procedures. If you look at clinical trials for many conditions, mainly acute leukemias, they are designed based on MRD. So a patient is MRD positive, you have to intervene. And many protocols are MRD guided to increase the rates of patients becoming MRD negative, molecularly, and possibly cured. From acute leukemia, this is moving into chronic diseases. I mean, MRD is used for chronic lymphocytic leukemia. There are many data here too. And trying to eradicate the disease, which is a revolution for that disease, in myeloma, in lymphoma. So it's going across the board, particularly in lymphoid malignancies, where most patients can be monitored, but also in some form of myeloma malignancy. So for us, this is a major change, and it ties to what I said earlier for CAR T, because I'm sure that CAR T will be used to get rid of MRD too. So the things are not too different, this point of discussion, but they're converging in the same direction. Yeah, that's another important point. I mean, the optimal monitoring of minimal residual disease is by molecular testing. I mentioned earlier you can do it by flow or molecular. Flow is less sensitive. Molecular is more sensitive. You go deeper. And technology evolving. I mean, as we talk, things move forward always. So even in science and research and technologies. I mean, the standard of molecular monitoring is by so-called quantitative PCR. Quantitative PCR is a standard, the guidelines say that, but this is changing. I'll give you a practical example. Now you can have more sophisticated technologies that are going down to lower levels, mainly by what we call digital droplet PCR, next generation sequencing technologies. These are not standard now, maybe not standardized guidelines are used now, but this will change very rapidly because we need always more sophisticated and practically used. So that is a change. And as I said, technology evolves as we are here, so that, but the timing of application clinic needs a little bit more time, but that's going to be the future. Well, I would put that in the context of the Congress here too. I mean, we're at the beginning of the Congress, but if you look at the program, many of the things we've been discussing today or incorporated in a presentations here, in a presidential best abstract, last breaking news. So these are the important points. Because, I mean, we talked about innovative immunotherapy. Let's keep in mind that the last Nobel Prize for Medicine was given for immunological procedures, not exactly CAR T, but it's in a setting of immunotherapy. So this is tying very well with MRD, and this is going to change that. The new drugs, targeted treatment, MRD monitoring, immunotherapy control, it's changing, I think, the paradigm of management of patients with hematological malignancy. This is very important also because, as a final point, let's remember that we are an aging population. We live in Europe. I mean, I live in a country where I think we're second only to Japan for the life expectancy. So the median life expectancy of a woman in Italy is 85, and a man is already 80, and less kids. So it's an aging population, and we're treating today and managing patients who are 80, 85, even with acute leukemias. So changes are phenomenal, particularly with targeted treatment and minimal disease and maybe immunotherapy.